Okay, our second speaker this morning is Adam Jaffe. Adam is Professor of Paediatrics at the University of New South Wales and Respiratory Paediatrician at Sydney Children's Hospital. Adam's interest is in translational respiratory research and good value healthcare. He's going to have a chat to us this morning about cough, I believe.
Thanks very much, Katie. Thanks for inviting me back. Last time was 1,000 miles, this time was 10,000 miles. So I'm hopefully just over my jet lag. And if I give a rubbish talk, I will blame it on that. Thanks, Mike, for setting me up for that. So I've been asked to talk to you about managing cough. So I want to tell you about a little story. It's a girl I look after called Alice. She's 7 years old. And her parents came to see me because she'd been coughing for many, many years. She had an uneventful pregnancy, born normal term, no problems. And then she had these episodes where she suddenly would start coughing for no reason. Sometimes there would be a prodrome, there would be an upper respiratory tract infection. There were paroxysmal coughing, dry coughing spells. Kept her awake at night, kept her parents awake at night. She was exhausted. She was struggling at school. Her parents were fed up and they came to see me. So, what did I do? Well, I'll share her journey with you because I wasn't quite sure what was going on. And so I entered what I thought was Alice's adventure in Cough Wonderland. I really wondered what was going on. So, I attended the European Respiratory Society meeting last year in Paris, and I went to a whole session on cough. There's this guy who spent his whole career doing this. This is electromyograph measurement of what cough is. And guess what? It's inspiration, there's a compressive phase, and then there's an expiratory phase and relaxation. His whole career. Extraordinary. I was quite amazed. That's a cough. That's a child from hospital not too far away from here, actually, with cough. And so that's essentially what coughing looks like. Now, it's important to understand about cough. Cough is a reflex. So you have a trigger. That trigger could be anything. It could be acid. It could be an upper respiratory tract infection. It could be inflammation, mucus. And then there is a expiratory phase, which I showed you with that compressive expiration type approach. But importantly, this is the bit you need to remember, is that there is a, head up there that's controlling it. So whilst it's a reflex that you're unaware of, there is an important bit, and I will talk to you about this important bit, because it's certainly in my practice, it constitutes a lot of it. And I'll talk to you a little bit about some of the stimulants that cause cough, but it's a reflex, normally completely unconscious. And they're the cough receptors. So you've got cough receptors in your large airways, you've got cough receptors in your heart, you've got cough receptors in your stomach. So you've seen children with acute pneumonia, they often present, poor old GPs, they get it in the neck because they're often presented with a fever, and it says viral, probably is viral, and they don't have a cough. So if you recall back to basic undergraduate medicine and the grey hepatization, red hepatization of pneumonia, remember that? There's a few lights going on. You don't have cough receptors in your periphery, in your parenchyma. So children don't cough in early pneumonia. It's only as it progresses and starts stimulating your cough receptors in your larger airways do they actually develop cough. So that's why they don't have it. There's a great case report in the Lancet of a child who presented with cough, and every time he poked his finger in his ear, he coughed, and it impacted wax, because Arnold's nerve, remember that? No, really? Yeah. Arnold's nerve is part of the vagus nerve, and he had impacted wax, and every time he stuck it with an earbud, he started coughing. Cough removed, and stopped when he had his wax removed. And that's really highlights the importance of understanding the reflex that exists for cough. It's very different from asthma. Now, you may ask me a few questions about what I think of cough variant asthma, does it exist, or cough predominant asthma, as it's now called. But it's a very different reflex from asthma, so important to realize that. And your stimulants are very, very different. There's the Cheshire Cat again. Now, for those of you familiar with Alice in Wonderland, now I had to revisit Alice in Wonderland. Lewis Carroll was off his face because there's absolutely no rhyme or reason for how these chapters evolved. But I tried to put the story together. And this is the cook in Alice in Wonderland. Speak roughly to your little boy and beat him when he sneezes. He only does it to annoy him because he knows it teases. I speak severely to my boy. I beat him when he sneezes, for he can thoroughly enjoy the pepper when he pleases. What am I going on about? The key in this, the pepper, capsaicin. So I can stop anyone coughing. I have the magic. I do have the magic. Okay, it's called lignocaine. Inhale lignocaine, you'll stop coughing. All right, it's a cough receptor. We just block it. Okay, it's on ion channels. We'll block it. But you need to cough. Clearly, it's one of your two protective mechanisms for your lungs, the most important organ in your body, despite what Mike says. Okay, he says being a respiratory pediatrician. The other, of course, being cilia. Now, you don't want to block, but you can. Cough is a science. So what you can do is block your cough receptors with lignocaine, and then use capsaicin pepper. 10-year slink, I know. You give pepper, and then you can actually measure the threshold by which cough starts again. So you actually can learn how different medications can prevent your reflex from making you cough. Extraordinary. Bet you didn't know that. So what's normal in children? How much cough is normal in children? As I've stood here, there have been various people coughing around the room. Some of them sounded a bit wet and need to see me afterwards. Others have been dry, and there's been a few psychogenic ones. Okay? So I know the poor bloke who actually put cough discs on children and counted them as part of his PhD in a hospital not too far away from here in South Kensington. So have a think. How many times a day is cough normal? Any ideas? Normal child. Don't be shy. 50? What? So the answer is 11, okay, on average. Although one child did cough 32 times, okay. So that's normal. So clearing your airways, coughing is completely normal. So you have to understand, as I do many times when children come to see me with their parents about their coughing, what's normal, what's abnormal, right? Basic pediatrics, understanding normality. So coughing 11 times a day is normal. But how long should you be coughing for? And so there's a little bit of disagreement between the Brits and the Aussies over many things, but particularly cough. The British Thoracic Society guidelines will say if you cough longer than 4 weeks, that's abnormal. The Aussies say if you cough longer than, the Aussies actually say 4 weeks, the Brits say 8 weeks. So this gives you an idea of what's normal and what's not normal, particularly when you're seeing a parent who comes and said, I just took little Jimmy or little Gemma to daycare, and you go, oh, here we go. I'm going to spend the next 14 minutes trying to explain to them this is normal. They get lots of snotty colds, and then they cough. And the important thing is, if that cough disappears spontaneously by 3 or 4 weeks, that's normal, okay? And understanding that premise of what is normal coughing reassures parents to say, look, and I'll talk to you about some techniques about how you can address cough, but that's normal, right? Getting snotty noses, and preschools will get 6 to 8 weeks, 6 to 8 infections a year. That's completely normal. So when you look at the BTS guidelines, British Thoracic Society guidelines on classification of cough, look at duration. There's acute cough with delayed recovery, there's recurrent acute cough, and there's persistent non-remitting cough. So if I see a child who's been coughing for longer than 8 weeks, then I'm excited, all right? That excites me because I think that I can do something here. I can investigate them because there's something going on, because I know that's my threshold. The most important bit in all this is taking a history. It's crucial that you listen very carefully to what parents are saying, because the answer is what they're saying. So ask them when they present with cough, what started it off? Was there a prodrome? Was it an upper respiratory tract infection? Was there choking? Right? If there's a witness event or any potential inhaled foreign body, then any suspicion, you need to see my ENT colleagues. How long has it been going on for? What's the quality of the cough? When is it worse? What makes it worse? When is it better? What makes it better? Is it getting better overall? Or really understanding, because that helps guide you to where you're going to investigate in the future. So the history is really, really important, as in with any pediatrics. The other thing that's really important, and I get this every single day, even though I'm over here 10,000 miles away from my new home, I'm getting videos every morning of children who are coughing. Because it's very important to understand the quality of the cough. Now, a lot of the work was done in East London by Sheila Mackenzie, assessing whether parents can actually understand the difference between the types of cough. Now, anyone here speak another language other than English? So think about, what is that word for wheeze in another language? And the answer is you don't have one, okay? No, it doesn't exist. Right? It's whistle. And parents are really rubbish when you're asked what are wheezes. In our international study of allergy and asthma in children, we don't ask parents, does your child wheeze? We show them videos, okay? And actually, junior doctors are not much better, sadly. But when it comes to cough, parents are brilliant at picking up what's a wet cough, what's a dry cough. So, what is that? The diagnosis is there for you. Yeah, it's croup, okay? It's a dry cough, sounds like a barking seal. It's croup, okay? Very important to understand. Next one. What is that one? Yep, pertussis. Okay, the dry cough. So, that's why my videos arrive on my phone every morning. What's the quality of that cough? Yeah, it's a dry cough. What's the quality of that one? That's wet. I get very excited with wet coughs, sadly. So yeah, understanding, listening to the quality. You haven't taken a history. You've just heard the quality, and I can work out what's going on physiologically, anatomically as well. So, what are the causes? How do we work out what the differential diagnosis is? So the way that the guidelines have, I don't know who writes these guidelines. Certainly wasn't me. They've classified them. Well, there's an expected cough. You've got an upper respiratory tract infection, you cough. You've got cystic fibrosis, you cough. There's a cause for it. And there's specific, because you've got a specific disease. And then there's the non-specific cough. Right, really? Who made that as a diagnosis? You've got non-specific cough, try it. I've tried it. Do you know the guidelines say your child's got non-specific cough? Really? Thanks. You're a genius. Thank you. Non-specific or viral-induced cough, post-viral cough. All right, so we're not very good at classifying what cough is. Now, I do want to take an opportunity to talk to you about wet cough. It's really, really important that you don't miss this, because this is suppurative lung disease. And it's very, very important, certainly where I work and with the Aboriginal population, this is often missed. And these children get into a lot of trouble. But even in non-Aboriginal, non-Indigenous environments, chronic wet cough, this is the pool of tears, in case you're wondering what this is about. And a wet cough for longer than 8 weeks, as I've already said, is very, very important. Because this is a concept of persistent bacterial bronchitis or protracted bacterial bronchitis. So this is usually caused by Haemophilus influenzae or Brandomella catarrhalis. And what happens is that the bug forms a biofilm on the airway and lives underneath there, okay, secreting its bits and making you cough, because actually you're trying to kill off the Haemophilus. And so what happens is children will get antibiotics for a couple of weeks, the cough sort of goes away like this, and it comes back again. Because you actually haven't killed the bug. All you've done is decrease the numbers, but it still sits in its biofilm. And we think that what we're seeing is a continuum of suppurative lung disease. You start off with persistent bacterial bronchitis, and then if you don't treat it properly, then you end up in a sort of bronchiectatic phase. So you actually get lung damage. And you've probably seen these adults now with severe bronchiectasis probably weren't treated appropriately early on with persistent bacterial bronchitis. Now, you can investigate this further by doing bronchoscopies, as they do in Queensland, where the queen of PPB lives, and you can do lavages. But actually, my current approach is just to give antibiotics. I tend to give a long course of antibiotics. I actually use azithromycin. It's actually very difficult to use in Australia. It's regulated only for pertussis and chlamydia, but I love it because I love its anti-inflammatory effects. I love its anti-biofilm effects. Remember, the children I'm seeing have already seen their GPs, had antibiotics, and so those very mild cases of PPB have improved, but I'm seeing the chronic relenting one. I'm an evidence-based person. There's no evidence for how long to give in PPB, and what I've done is extracted the evidence for cystic fibrosis and in bronchiectasis, and I give children Monday, Wednesday, Friday, usually for about 4 to 6 weeks. The idea being to break up the biofilm, kill the bacteria, and allow the underlying respiratory epithelium to recover. And their persistent bacterial bronchitis tends to get away. Why healthy children get it, it's very difficult to know. Some people think that may be a minor immune defect, which tends to improve with time. But the take-home message is a wet cough longer than 8 weeks is not normal. Okay? Do not send people home away saying that's normal. Your child's going to preschool. It is not. Another bit of my practice, actually this is mostly my private practice. Hear that? I can sit in my room and hear them in the waiting room, and I go, anyone know what that is? There's the Mad Hatter. Psychogenic cough. So I know it's going to take me 30 seconds to make that diagnosis. It could take me 45 minutes to convince the parents that it's their fault. Oh, sorry, not their fault. They're part of the solution. So it's really interesting. So the history is key. And if you let parents talk, they will tell you. They'll say, oh, you know, the cough's really bad. It's driving us nuts. They use those words. It's driving the teachers nuts, driving the child nuts. And that as soon as they go to bed, it's worse before they go to sleep. Much worse. Sleep is a scary time. Mike didn't talk about how scary it is for children to go to sleep. Crocodiles under the bed and stuff like that. And as soon as they fall asleep, and that cortex, that bit there, switches off, it's gone. Completely just, and they will say in the morning they're awake. I can hear them like an alarm clock. That's the diagnosis, psychogenic cough. You don't need any other tests. Now, how do you manage that? Well, it's very interesting because the group at the Brompton, and that they will comment that most of them come from private practice, and certainly in my practice it is private practice, high schools. I can usually pick the schools. This is really a psychogenic external response to stress. And if you look at habitcough.com, you'll see a really great display of how you stop the cough. Basically, you drink water every time you want to urge. And this Miles Weinberger, the doctor who runs the website, it's like a miracle. Except that it's not really, because in Ian Balfourlin's series, 18% went on to get another psychosomatic disorder. They developed tics or other problems. My approach is actually to approach the roots of the problem from the psychogenic perspective, actually having seen a psychologist. You can switch off the cough with your water technique, hypnosis, and even there's an anti-Tourette drug, which we wrote up a very scathing letter in the Lancet many, many years ago saying we really should be approaching from a psychological perspective. There's a reason children have conversion disorders, and it's a tic, essentially. But thank you. Okay, next slide, please. Okay, anyone, could you, there we go, thank you. Okay, I'm going to talk about that. Sleep, I'll put that in for Mike. It's very, very important that anything bad with coughing, if you cough at sleep at night time, something's wrong. If you don't cough at night when you're asleep, then you certainly don't have it. What investigations do you do? What rabbit hole do you go down to? You're really guided by your symptoms and presentation. So chest X-ray, CT scan, weighing up the risk of cancer with a CT scan, bronchoscopy, lavage, barium swallows if you're thinking there's on history, aspiration potential. What about treatments? First of all, over-the-counter treatments do not work. They make you feel better, They don't work. They're associated with a lot of side effects. And they just don't work. So please do not prescribe over-the-counter medicines. There's no evidence that they work. I thought I did find it in Camden Market many, many years ago. I found a bottle that said long tonic on it. But actually, when you look closely, you can't read it, but it does say poison on it, which is a little bit disappointing. But I will give you some advice. You can reduce the cough receptor sensitivity by simple measures. Vicks on the chest. Okay? Menthol, our adult colleagues will use Fisherman's Friend. Menthol reduces the cough receptor. Remember I talked to you about capsaicin, and you can actually look at the threshold. Vicks on the chest, is at least 2 studies will show that parents sleep better, children sleep better. Tricks them into sleeping better, okay? No evidence of Vicks on the feet, 1.5 million Google hits, okay? Lemon, spoonful of lemon, spoonful of honey a day. Spoonful of honey a day, very effective, and even chicken soup, some dodgy evidence for chicken soup. Avoid environmental tobacco smoke. Avoid things that will stimulate cough. Okay, smoking is crucial, right? I never smoke in a house, doctor. Just in the salivary test of your children, we can test. Okay, so those are some of the avoidance. So what happened to Alice in the end? Well, I tried all the cough reduction measures I tried. We investigated her for reversibility on asthma treatments, didn't have any. I gave her high-dose inhaled steroids as evidence that high-dose inhaled steroids reduces cough receptor sensitivity. I even gave her amitriptyline. Why? So there's a concept of neurogenic cough. Chop off your arm, you still have a phantom limb. In the adult world, there's a concept of neurogenic cough. Essentially, it's a bit like pertussis, the 100-day cough. Why do you cough for 100 days? It must be neurogenic. So there's evidence that gabapentin, amitriptyline works. And so I even tried her with that. What happened? She just stopped coughing. I don't know what I've done. She just stopped. I got an email from her mum this week, actually, saying, should I come see you again? She's been absolutely brilliant. She's on no treatment. I think maybe, perhaps like Alice, I just woke up and it was all a dream. Thanks very much.
Thanks, Adam. That's fantastic. Claire, what have we got from Twitter?
So we've got a few questions. So really simple things. I think probably a few of us were thinking this. You see a child, you're fairly convinced there's a psychogenic cough. Anxious parents, as they always are. You've convinced them the child's thriving, as they always are. Would you ever recommend doing a chest X-ray for probably more of parental reassurance than anything else before going down the psychogenic cough route?
So do you mean parental reassurance or doctor reassurance?
A bit of both, probably.
Yeah, so you've got to have the confidence. And so the only test I do would be spirometry.
Okay.
And the reason I do it is because it's non-invasive, doesn't involve radiation, and I give it up to the parents. I remember a letter I got from a dad said, thank you very much for help with little Tabitha's asthma. She didn't have asthma. Mm-hmm. She can't go see the psychologist. She's too busy with ballet and flute and guitar, and I mean, that's the problem, okay? Mm. So, no, I actually do spirometry because of the radiation, and it really, sometimes children just need a bit of get-out clause. You know, sometimes if you worry they've got postnasal drip and you can treat allergic rhinitis, sometimes they just need that to stop. But I really think about treating the underlying cause, and from a psychological perspective, it's crucial because 20% of Ian's patients went on to get another psychosomatic problem.
Lovely. So that leads well into Emily Pascoe's question. Does cognitive behavioural intervention in tics work for psychogenic cough?
So yes, so they certainly, there's definitely CBT will be helpful as long as it involves, again, addressing the underlying problem. And I will often, as an example, ask children to download Smiling Mind app, which is an Australian app, which is really good for helping mindfulness as an approach. So those sort of approaches is what I take. But as I say, the Americans will disagree with me. They use hypnosis. They use the water technique. It's not my approach. But yeah, CBT will definitely be helpful as long as you approach the underlying. It's not about stopping the cough. It's the cause.
Okay, lovely. Thank you. That's all from Twitter.
Anything from the room? Yep.
Hi, thank you so much for such an informative talk. I'm a GP from Perth in Australia. I have a question about how you would approach the conversation with parents about it being a psychogenic cough, like the 45 minutes? What are your tips to sort of that conversation as a GP to have with parents?
Yeah, no. So it's a really good question. It really depends on what your during the consultation, what your feeling is about the parents. So you probably you may have a really good relationship with parents beforehand. Sometimes parents will you get a feeling that they actually thought about it, and they may say, I think it might be a habit, and that's a hook to actually reinforce their belief and help them. So it really, really depends. As I say, that father was really resistant. That child would have gone on to have hair pulling at some point. So it really depends on how that therapeutic relationship goes with the parents, how you feel that is. So often parents are very, very relieved, and I'll give them some information. I send them to habitcough.com. I'll print out some stuff on habit cough. And also the fact that my daughter had it when we moved to Australia, it was actually quite helpful because I can sympathise 100%. But that's she probably won't thank me for saying that. Now she's 21, she has different problems. So it helps me because I've been there and I understand how as a parent it's really tough because you think you've done everything to protect your child and yet you expose them to an environment which is stressful. So every approach to parents is completely different depending on what your gut's feeling is going to go. Mostly I get round, but I usually have 45 minutes. So as a GP and with 6 to 10 minutes, I think it's really tough actually. habitcough.com.
Thank you so much, Adam. I think we need to move on. Thank you.
Thank you.